All right, let's break pheochromocytoma down in a USMLE style, high-yield way so it sticks in your brain like your favorite mnemonics. Clinical picture, classic triad plus more. If you see a patient with 1. Headache, 2. Palpitations, 3. Sweating, diaphoresis, and episodic hypertension, immediately think pheochromocytoma. This is the classic triad. Other possible features: anxiety, sense of doom, tremors, flushing, orthostatic hypotension because chronic catecholamine release, volume depletions, alpha receptor desensitization. Mnemonic, pheochromocytoma, P, palpitations, H, headache, hypertension, PH, flushing, diaphoresis, sweating, E, episodic, paroxysmal attacks. Remember, symptoms often come in bursts, paroxysms, due to sudden catecholamine release. Now hashtag pathophysiology, tumor of chromaffin cells in the adrenal medulla, neural crest origin, secretes catecholamines, epinephrine, adrenaline, norepinephrine, noradrenaline, and sometimes dopamine. Hormone release is often triggered by exercise, stress, surgery, anesthesia, certain foods, tyramine. Hormonal profile, catecholamines, epi and Ne, metanephrine's metabolites, more stable, so better for lab testing. Vinyl mandelic acid, VMA, in urine, breakdown product. USMLE pitfall, not all patients are hypertensive 24/7. Up to 50% have episodic spikes. Can cause paroxysmal hypertension, mimic panic attacks. Orthostatic hypotension possible because chronic catecholamine excess, vasoconstriction, decreased intravascular volume. Diagnosis: 1. Best initial test, plasma-free metanephrine's, high sensitivity. 2. Confirmatory 24-hour urinary catecholamines plus metanephrine's. 3. Localization, MRI or CT of abdomen pelvis. Management: first, alpha blockade, phenoxybenzamine, irreversible, for 10 to 14 days. Second, beta blocker, after alpha blockade, never before. Definitive, surgical resection. Quick USMLE trigger: a patient with episodic headache, palpitations, sweating, anxiety, and hypertension who worsens during surgery. Think pheochromocytoma. Always stabilize with alpha blockade before surgery. Here's a combined package with both the riddle plus options and the USMLE clinical question plus options. I dwell inside the adrenal medulla, born from neural crest cells. I strike in sudden storms, pounding headaches, racing heartbeats, and drenched skin. Seen on MRI as a shining mass, I'm dangerous if you tackle me wrongly. Before you cut me out, you must first shield the vessels, or face a pressure spike that can kill. Who am I, and what's the first step in taming me? Options: A. Pheochromocytoma, A blocker. B. Pheochromocytoma, B blocker. C. Cushing's syndrome, steroid taper. D. Neuroblastoma, immediate surgery. Carcinoid tumor, octreotide. USMLE-style clinical case with options. A 35-year-old woman presents with episodes of pounding headaches, palpitations, and profuse sweating lasting 20 to 30 minutes, occurring several times a week. Her blood pressure during episodes is 180 to 110 millimeters Hg, but normal between episodes. Laboratory studies show elevated plasma-free metanephrine's. MRI reveals a 3-centimeter right adrenal mass. What is the most appropriate initial step in managing this patient before surgery? Options: A. Initiate beta-adrenergic blockade to control tachycardia. B. Begin I-adrenergic blockade with phenoxybenzamine. C. Start methimazole therapy. D. Administer calcium channel blockers. E. Begin chemotherapy. Correct answer for both.